Good evening. My name is Mark Clark, and I'm the Technical Assistance Manager for the Division of Technical Assistance in the Technical Assistance and Research Center for the National Council of Urban Indian Health. I'm pleased to welcome you to our training on governance, board governance, entitled The High Performing Boards in a Virtual World. I want to welcome you to the opening session of our 6 sessions held over 3 evenings from April 14th through May 12th. If you're looking to join us for the governance and training session, you're in the right place. I'd like to encourage you to put your name, your organizational affiliation, and organizational position and tribal affiliation in the chat box as you enter. We'd like to keep track of our audience. We encourage you to be engaged in this interactive session. Well, it's a few minutes after 6 p.m. We'll go ahead and get started. We want to be respectful of your time. So I'll ask our control room to advance the next slide. Again, my name is Mark Clark, and I'm the Technical Assistance Manager for the Division of Technical Assistance. I'll be your host tonight, and we'll look forward to moving you through this evening's presentations at a comfortable pace. Thank you. Ready for the next slide? NIKEI is the National Council of Urban Indian Health. We are the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NIKEI is the only national representative of the 41 Title V urban Indian organizations under the Indian Health Service in the Indian Healthcare Improvement Act. NIKEI strives to improve the health of the over 70% of American Indians and Alaska Native populations that lives in urban areas supported by quality, accessible healthcare centers. Next slide, please. Tonight's agenda is again, we begin at 6 p.m. We'll try and get through our introductions, and our first presentation will be offered by Kimberly Fowler. We'll get to our next slides. We'll just to alert you, there'll be a break in the middle of the evening at 6:45 to 7 p.m. and then we'll immediately go into our second presentation for the evening, presented by Evie Maho. Next slide, please. A few notes about housekeeping. This webinar is being recorded and it'll be available for download fairly rapidly on our homepage. Your mics have been muted unless otherwise noted, and will be kept in that fashion unless there's an opportunity for an interactive conversation, in which case mics could be unmuted by raising your hands. We'll listen for directions on that. We'd like you to turn your camera on to allow for interaction and maximize our opportunity to engage with one another. Tonight's session, again, is 2 45-minute sessions. Throughout the sessions, questions can be typed into the chat box, and we'll carefully monitor the chat box so presenters will be made aware of questions. In our particular opening sessions, the Q&A session will be offered at the end of each session. So we'd ask that you patiently hold those questions to the end, and we'll make sure that they all get addressed. Again, slides and the recording will be available at the landing page for our board training at the NIKEI webpage. There'll be an evaluation that follow at the end of the session, and of course, we value your feedback. We strongly encourage you to complete those evaluations, which only take a couple minutes to complete, so we can make sure that we're addressing your needs and answering your questions, and most of all, serving you as efficiently and effectively as we can. Again, your feedback is very important to us, so don't forget to take our survey. Next slide, please. For those of you unfamiliar with Zoom and how to ask a question, it's fairly straightforward. You select the chat feature at the bottom of your Zoom screen, where that red arrow indicates it. You can type your questions into the chat box, again, adding your comments, and we'll keep track of those. The comments will appear on the right-hand side of the screen. We'll carefully monitor that chat box so that we're sure to address all the questions with our presenters and our expert presenters. Next slide, please. Presenters this evening are Kimberly Fowler and Evelyn Maho. Let me offer this quick bio description for both of our presenters. Dr. Kimberly T. Fowler has been working to support Indigenous communities for nearly a decade. Dr. Fowler has been employed at NIKEI since 2011, and as the current Vice President of the Technical Assistance and Research Center, has led various projects focused on capacity building and sustainability of urban Indian organizations. She's developed programs to support operations and programmatic growth, as well as increasing research centered on the urban Indian health sector. She received her Ph.D. from Yale University, a certificate in public health from the University of Colorado of Health Sciences, and a bachelor's in science from Tennessee State University. Dr. Fowler will be this evening's first presenter. Our second presenter is Evelyn Maho. Evelyn is Diné from a small remote community of the People's Water, western portion of the Navajo Nation, northern Arizona. Evelina has delivered board of directors trainings for Southern California Consortium, in Albuquerque area Indian Health Services, boards of directors, and other C-suite leadership trainings. Her career track has entailed collaborative work with tribes, hospitals, particularly IHHS 638 facilities, and urban Indian health centers, administrative, fiscal oversight, project design, and implementation are her focus areas. Early in her career, Evelyn decided to focus on public health prevention and the management of chronic diseases among American Indian populations. Her training began at Northern Arizona University. She's an alumni there with a Bachelor's of Science in Food and Nutrition Sciences and a minor in chemistry. She obtained her master's in administration with an emphasis on health sciences and healthcare administration. So again, those are tonight's presenters. Next slide, please. Well, we've done our welcome and introductions. The next portion of this evening consists of pretest questions. We actually build knowledge checks into each session, not only to offer insights into the effectiveness of our training, but we have certified that we will not only keep track of training hours provided to our audience, but also knowledge gains that we can document for our audience. So that's the rationale for our pretest questions. So we've done our welcomes and introductions. Without further ado, I think we can load our pretest questions, and then the next voice you'll hear will be Kimberly Fowler. Without further ado, ladies and gentlemen, Kimberly Fowler.
Thank you, Mark. I appreciate that warm introduction. Again, my name is Kimberly Fowler, Vice President of our Technical Assistance and Research Center here at NIKEI. I'm happy to share this information tonight with you on the brief history of urban Indian health organizations, also known as Title V nonprofit organizations. I don't claim to know everything, but I hope that you'll gather a lot of information that will help support you, and especially if you're a new board member, understanding more about how our urban Indian organizations were, or came to be, I should say. The way that I kind of think about this is that when we think about relocation, it really has been endemic to modern American Indian history. You can think about under or during US expansion, during the 19th century, large numbers of American Indians were forced to relocate west. And even in 1830, Congress passed the Indian Removal Act, which authorized the president to conduct treaties to exchange native land east of the Mississippi River for lands west of the river. And this kind of set precedents of that relocation era that was occurring, but also resulted in over 100,000 American Indians actually eventually relocating to the West. Now, when we kind of move more into the 1900s, prior to 1950s, most American Indians lived on reservations in nearby rural towns or even in tribal jurisdictions in areas such as Oklahoma. But we know that from 1948 and well into the 1980s, the Bureau of Indian Affairs established a relocation program. And this program was seen by many as an attempt to assimilate American Indians and Alaska Natives into city life, thereby removing their practice of Native culture and traditions, as well as drastically undermining the reservation system. Now, in between there was termination policies that were in effect that really stripped tribal citizens of their federal recognition, if you will. And unfortunately, during that time, even moving forward today, there are still tribes that are not recognized federally because of this practice. So as the relocation occurred, healthcare was provided for about 6 months during relocation by private providers. And this actually kind of set precedents for healthcare, if you will, that in some ways was afforded those that did relocate. The federal government's trust responsibility towards American Indians and Alaska Natives really entails a legal obligation to look out for the welfare of tribal members. This trust responsibility was created by many treaties that were entered to by tribes and the US government, and was for the large part guided by a somewhat paternalistic outlook on Native life. Now, over the years, the trust responsibility has been solidified in law and policy, and the supply of access to healthcare remains one of the central tenets of the trust relationship. This eligibility did not change due to government relocation activities, which kind of affords why the IHS system kind of remains to this day. If I could have the next slide, please. So when we think about healthcare advocacy, that really was the bedrock of how urban Indian organizations came to be. We know that in the late 1960s, urban Indian community leaders began advocating for local, state, and federal levels for culturally appropriate health programs addressing the unique social, cultural, and health needs of American Indians and Alaska Natives residing in urban settings. These community-based grassroots efforts resulted in programs targeting health and outreach services to the Indian community. The programs that were developed at the time were in many cases staffed by volunteers, offering outreach and referral type services, limited primary care, and maintaining programs in storefront settings with limited budgets. This kind of set precedents for some pilot programs actually to come to be. So some of those founding UIOs were in Rapid City and also in Minneapolis areas where some of that advocacy was taking place. And we know that by the 1970s, there were federal appropriations under the Snyder Act that actually provided for healthcare in these urban areas. Interestingly, the Indian Healthcare Improvement Act, which was founded in 1976, actually defined urban Indian organizations and actually was the foundation for the provision of healthcare in urban settings for American Indians and Alaska Natives. This was what came to be known as Title V for urban Indians, and so you'll kind of hear that frequently throughout this presentation too as well. So all urban Indian organizations are defined as Title V programs. Next slide, please. So as I mentioned, this federal trust responsibility came to be out of, for health that is, came to be out of the Indian Healthcare Improvement Act, which has had several amendments over the years. And specifically in an amendment that occurred in 1987, without reading through this whole paragraph, but really looking at the highlighted red areas, the responsibility for the provision of healthcare services follows them there. Them recognizing being American Natives and Alaska Natives that are now residing in urban settings. And this is the precedent in which NIKEI also uses to advocate for that federal healthcare trust responsibility too as well, knowing that healthcare is a provision that should follow and be present no matter where you reside. Next slide, please. And so just trying to think through what does urban Indian need, I thought I would place some definitions here that actually, depending on where you reference it, means different things. One significant one is the Affordable Care Act. But knowing that in essence, an urban Indian would be an American Indian or Alaska Native individual who lives in an urban or suburban area. It may be a permanent resident, but it also may be something more long-term, especially if it's for someone that's left the reservation for school or to find job opportunities. And so this is more of a short-term visitor, if you will, to the area. There are more than 70% of American Indians and Alaska Natives live in metropolitan and urban or suburban areas. And there are definitely some issues surrounding the population when we think through the eras of migration, the identity challenges that may come to be as the generations now reside in urban areas, and then other perspectives that have been held throughout even some federal bills that have come to be, in thinking about those perspectives of intertribal relationships. Next slide, please. So when we think about these Title V programs, that Indian Healthcare Improvement Act, also known as IHHS, I'll start saying IHHS, actually provides health services specifically for medical, alcohol, mental health, HIV, health promotion, and disease prevention. But we do know that our UIOs provide a full array of services beyond this. Next slide, please. I wanted to draw your attention to this slide just to give some basics around where the urban Indian organizations reside within the ITU system, where Indian Health Service may provide direct care and service through clinics and hospitals. Tribes also have the ability as sovereign nations to provide their own healthcare for their own people. As sovereign nations, these are called 638 contract programs. And these contracts are through IHS to provide those health services directly. And then urban programs are actually nonprofit organizations in which they receive their funding through grants and contracts for direct care. And interestingly, you'll see throughout this presentation that only or less than 1% of the IHS budget is dedicated to this urban line item. Next slide, please. So who do urban Indian organizations serve? We can think about this as UIOs providing care and treatment to urban Indians, tribal members of federally and state recognized tribes, their descendants, Alaska Natives, and individuals determined to be eligible by the Secretary of State. And so this also includes individuals that are Alaska Native, Eskimo, Aleut, and considered, as I mentioned, considered by the Interior Secretary to be Indian. Next slide, please. So I wanted to share a bit about some of the statistics around from the Census Bureau that we know when we think about the data coming out of the census on urbans themselves. As I mentioned, actually closer to 78% live outside of reservation areas. And specifically in 2019, our urban Indian organizations actually provided services to 529 of the 574 federally recognized tribes. This is about 92.5% of tribal members being served by urban Indian organizations. only 427,000 of urban natives either receive care through IHS or Tribal 638 facilities due to geographical locality. So you can think about this as being the majority of that number, or of the total number, being receiving private facility care through private insurance or through a UIO. And as I mentioned before, less than 1% of that budget is dedicated to UIOs. Next slide, please. So urban Indian health programs themselves, there are currently 41 urban Indian organizations. Most are FQRTs, federally qualified health centers. They fall into an array in which they provide services spanning from outreach and referral programs, limited ambulatory services, full ambulatory services, as well as inpatient services through residential treatment centers or substance use inpatient services too as well. Our UIO programs do have limited legislative authorizations and appropriations in relation to what is received by IHS facilities or 638. So as I mentioned, there is that one line item within the IHS budget that funds UIOs. We do know that over 100,000 urban natives are not able to utilize IHS or it is not present in their delivery service area. And this is where UIOs really tend to provide that additional care for those services. Interestingly, I'll provide some more information on the public health aspects and health status of urban Native Americans on another slide. So, but knowing that there are similarities with those health statistics and disparities that we see. Next slide, please. So when we think about some of the budgetary and funding of UIOs, we know that there is a tribal budget formulation work group that meets annually that actually recommends the amount of funds that would be dedicated to each of the line items within the IHS budget. This is used to then appropriate funds through Congress, as well as the president's budget also relies on this information to create its budget, or their budget, I should say. Interestingly, we've seen great increases over the last 2 or 3 years through this budget formulation process. And actually this year, there was a recommendation for $90.94 million increase to that urban Indian line item. Now, whether that becomes appropriated or not is yet to be seen, but it is a big win for urban Indians. We know that there are, as I mentioned, additional funds are distributed through grants and contracts. So if you think about the special diabetes prevention for Indians, the domestic violence prevention program, even the 4-in-1 program that provides some of those health and immunization services for UIOs, there's opportunities there to receive additional funding for each individual UIO. The distribution of these funds is based on historical funding. So unlike tribes, I should say 638 programs in which there's a formula that's developed and improved upon each year. The UIOs really are kind of set at a base level of funding, and any increase is just kind of added on top of that base funding. It is projected that this funding level only meets 22% of need for primary care services through the UIO. So there's definitely room for improvement in achieving health equity through our UIOs and actually across the whole ITU system. Through a needs assessment that came out in 2018, it was determined that there are actually 18 additional cities that could be eligible for a UIO, as they were identified of having a large urban population that could be supported by an urban Indian organization. Next slide, please. So I just wanted to give a snapshot view of what the line items for IHS looks like. And so in yellow, you'll see that one distinct line item for urban Indian health, which you can notice that that means that urban Indian organizations don't have access to even infrastructure support, sanitation facility support, construction support, which is important in the continual improvement and enhancement of facilities for our UIOs. And this is actually from the fiscal year 2019 line item. Next slide, please. So UIOs, as I mentioned, receive that one line item, but there's are additional ways in which UIOs can thrive with funding through third-party reimbursement. This third-party reimbursement can come through Medicare, Medicaid, CHIP, Veterans Health Administration, and private insurance, which really does support programs in spreading out, if you will, the funds to provide to their patients. NIKEI does advocate and work for increases, especially to Emergency Third-Party Reimbursement Relief Fund, most recently, which could provide additional funding in emergency circumstances, even circumstances such as COVID. I have the last bullet point here just as a reminder that there are other cost-saving measures that IHS and 638 tribal programs receive that UIs have not received in the past. But I have to say we've had some big wins over the course of the last year, more specifically in the last couple of months, in which some of these ineligible measures actually are now in place for our urban Indian organizations. So you may have heard many discussions around 100% FMAP and the federal rate, which leads to higher Medicaid reimbursement rates for states, which could be put back into the care for UIOs. You've FTCA malpractice coverage, which allows for reimbursement of malpractice insurance for UIOs. A lot of UIOs spend upwards of $250,000 per year alone on malpractice insurance. So this will definitely help to reduce these costs and expenditures. And then lastly, the VA reimbursement, which allows for dually eligible American Indians, Alaska Natives that are seen at urban Indian organizations to be reimbursed for that care through the VA. Next slide, please. So this just gives some important characteristics of UIOs that we know of. I've already mentioned that they're nonprofit organizations. They are governed, or all UIOs are governed by a board of directors that has to be at least 51% urban or American Indian, Alaska Native, I should say. And then also understanding that there is a unique aspect of UIOs and that they are providing culturally appropriate and quality healthcare services, even in those urban settings. So that does, I think it provides like that care that many would not receive if they went to a private medical doctor or medical facility. And there's definitely a sense of home when attending a UIO. UIOs are definitely supportive of tribal values and making sure that they are, of course, founded under those values and cultures, but also making sure that they're serving as safety nets for individuals in urban settings. As I mentioned, they are FQACs. Next slide, please. So I wanted to just share this map of our urban Indian programs across the nation. So each blue dot represents each of those UIOs. And next slide, please. So when we think about UIOs, we know that there is a need for funding. We know that majority of American Indian Alaska Natives reside in urban areas. But we know that our UIOs actually are thriving in that within those 41 UIOs, they actually are able to provide care through 77 facilities in 22 states. Interestingly, the current budget at 57.68 million does have to be spread across those 41 UIOs, but there are so many great things and great aspects from your programs actually that are provided to your patients, even with those limited funds, if you think about spreading that across 41 programs. There are, as I mentioned, some access line items not available to UIOs, and you can see some of those listed here as well. Next slide, please. So for the current year, the budget proposal is approximately $49.6 million for the president's budget. So we're hoping that this continues to increase over the course of the years, but also knowing that the actual IHS total budget authority is 6.2 billion. And so you can see that there's a wide disparity there when thinking about the additional funds that might be available for UIOs. But I have to say that NIKEI definitely advocates in a way to recognize tribal sovereignty, and only really looks at ways in which that line item and that UIOs receive their funding through is increased, not really taking from other line items within the IHS budget. Other bullet points on this slide really are just speaking to the proposed budgets for fiscal year 22 that came out of that tribal budget formulation. And I've kind of spoke of that already, and these slides will be readily available for you to see in the future. Next slide, please. So I wanted to briefly touch on the unmet needs of UIOs. I spoke about only meeting 22% of the needs through the budget line item, but also putting that into perspective of what that care means for patients in the ITU system, as you can see here in this graph. We know that $11,172 are dedicated per person for US healthcare in general. However, only $4,078 per person are dedicated for patients in the IHS system. And unfortunately, that also starts to dwindle down when we think about the UIOs and their line items, in which only $672 per American and Alaska Native patient is dedicated. Next slide, please. So despite this lack of funding, we know that our UIOs are still able to utilize those funds and provide primary care services, a variety which are listed here, even specialty care such as optometry and dental services, and even social services and pharmacy services. Next slide, please. This is just another view of those services and thinking about the fact that it's more than just primary care. There's behavioral health services, social and community service, such as job placement, prevention, education, youth camps, traditional healing and medicine that's also provided through some programs, even provide their own sweat lodge ceremonies. And of course, there's gatherings and talking circles that occur at our programs. Next slide, please. So these services definitely meet primary and secondary care services. And just wanted to make reference that purchase referred care is not received at our UIOs. And so unfortunately, these fundings are lost once someone moves to urban areas unless they go back home to receive care. As I mentioned, there's other ways of and alternative resources through federal government healthcare and insurance. There's Social Security, Medicare, and Medicaid, and of course, third-party billing. Next slide, please. So we know that as I already mentioned, the UIOs definitely are able to understand and recognize the health priorities of care for their own communities. There's also opportunities to look at urban Indian organization profiles through the Urban Indian Health Institute, which has profiles dedicated to each UIO. And this kind of helps to guide development of new programs, understanding how you can allocate resources using that information, and also really look at statistics and figures that could support you in grant writing. Next slide, please. There is IHS reporting requirements that's required by IHS for all UIOs. I think we probably all in this room recognize that RPMS is the electronic health record system that is used at IHS, but also understanding that there are data reports that are required from UDS and GIPRA, Government Performance and Results Act, but understanding that this information is what is aggregated and actually provided to Congress when helping them to make decisions about funding for UIOs as well. And so there's a link there if you wanted additional information, but these reports are required across the whole ITU system. Next slide, please. And I can skip this slide, it's already been stated. And this is just noting that there are health disparities across Indian country, and recognizing that those health disparities also are seen in our urban areas. The top 5 leading causes of death are heart disease, cancer, diabetes, chronic and liver disease, cirrhosis, as indicated here. You can see there's definitely a significant higher rates of death. Next slide, please. We've even seen that through COVID, understanding that this actually acknowledges in general, low income and communities of color are at higher risk of serious illness if infected with COVID. And we can see here that it specifically states that 1 in 3 American and Alaska Natives are at a higher risk of serious illness. And so we do share this with Congress, with federal agencies, especially in promoting ways in which they could improve access to funds for their federal agencies. Next slide, please. I just wanted to shortly make mention of advocacy groups. I think we all know that together we are stronger. So not only does Indian Health Service, but national, of course, NIKEI, our California Consortium of Urban Indian Health, which is also known as NCUIH, the National Indian Health Board, which is our sister agency, along with the National Congress of American Indians, all fight the fight to ensure that your programs and your facilities receive adequate healthcare funding and services. Next, please. Next slide. Mark has already mentioned about NIKEI, so we can go to next slide. Just wanted to make mention that NIKEI was founded in 1976. We are a part of that IHS budget and the urban line item in some of the funding that we receive. But as I mentioned before, we always support full IHS funding for tribes as well as UIOs. Next slide, please. These are the top service priorities of UIOs from a 2020 survey that NIKEI put out, but just recognizing that health information technology, dental services are all areas of concern and priority for UIOs. Next slide, please. I will reference this slide only to say that through the work of NIKEI, we do advocate and have legislative priorities that our policy team daily looks into. And I just kind of checked off some of those areas in which we've had great strides and have been able to actually meet some of those parities for urban Indian health, as well as appropriations for health. And these legislative priorities can be found on our website, and we'll provide that link later. Next slide, please. This was just a visualization of that information, but denoting that the top 3 of these priorities have actually been met. The HIS-VA, the parity for UIAs with FTCA, and the 100% FMAP. Next slide, please. And this is just knowing that, as I mentioned, strengthening partnerships. We know that NCUIH, UIHI, and NIKEI all work together with UIOs to ensure that there's culturally competent health services being provided for American Indian and Alaska Natives living in urban settings, and that there's strength in unity. Next slide, please. And to close us out, I just wanted to speak about the fact that although I've kind of mentioned some areas of improvement that are needed when we think about the funding, when we think about access to care, and some of those health priorities that the UIOs have, there are definitely models of success that we see. In calendar year 2020, our 41 urban Indian organizations provided over 750,000 healthcare visits to 90,094 urban Indians at their settings. And those numbers are steadily rising and increasing as we continue to get information in on calendar year 2020. I also wanted to note these two programs that I've listed here, just to give example of some of their services that they have been able to provide, which are I would say rather unique in that they've actually been our First Nations Community Health Source, which is in Albuquerque. They've been providing holistic care, traditional practices at their facility. And most importantly, providing space for the homeless. They have a special area for their homeless to receive healthcare, to be able to take showers and receive from their food pantry. And then the Nebraska Urban Indian Health Coalition, which is located in Nebraska, they also have a program for their elders, their native elders called Tired Moccasins, in which they're able to provide, or before COVID probably, able to provide a lot of these services. We've all moved to a lot of virtual platforms, but really being able to provide arts and crafts and low impact exercises to their elders. Next slide, and I'll close this out just by saying that we really thank you for your efforts, because you being a part of the Urban Indian organizations as board members really gives life to the organization in setting their fiscal as well as some of their healthcare priorities in the way that they meet the patients that they see. I put this quote up here just to kind of really make it more personalized, but this came from one of our surveys in which a focus group was happening, and the person just said that the last person of the day is a tribal leader. Her daughter just committed suicide that morning. She couldn't say a word. There was just no point in interviewing her. I just held her in my arms and sang her one of my traditional songs and prayed hard. No, you just can't teach this in a medical school, was what this individual shared with us. So knowing that our UIOs are more than just healthcare centers, they're a center of support, they're a center of a way in which those that sometimes see themselves as invisible in city settings have a place to be able to share, to commune, to even eat together and just share their experiences. So once again, I thank you for your efforts. And with that, I'll close us out for this session. And I'll turn over to Mark, I'm sorry.
Thank you. Thank you so much, Dr. Fowler, for an informative presentation.